and welcome to the first reconstructive episode of Sientra TECHnews. I am pleased to introduce a phenomenal breast reconstruction panel today. Out of the West Coast, first is Dr. Arash Momeni, Assistant Professor of Surgery in Palo Alto, California. Welcome, Arash.
Very much looking forward to the discussion with truly outstanding surgeons and close friends of mine.
Great, thanks for being here. And out of a more central region is Dr. Peter Koltz, the lone wolf from Toledo, Ohio, doing breast reconstruction in a community setting. Welcome, Peter.
Thanks, Blaine. It's a pleasure to be here with Arash and Suhail and you. And these are some great thinkers, and I'm looking forward to some good discussion today.
Great, thanks for joining us. And last but certainly not least, from the East Coast is Dr. Suhail Kanchwala, Assistant Professor of Surgery out of Penn.
Thanks, Blaine. Excited to be here.
Great, guys. So thank you very much for being here again. And first, as we've done in the past, we'll start off with a short presentation on some concepts that will lead us in discussion later. So for that, let me reintroduce Dr. Arash Momeni.
Thank you very much, Blaine, for the introduction. It's a true privilege to give a very brief overview over advances in technique and technology related to breast reconstruction, specifically implant-based reconstruction. And I'm very much looking forward to the ensuing discussion with the panelists. I think that whenever you talk about breast reconstruction in general, it is important to remind yourself where we've been and where we are today. And we have seen a tremendous change over the past few decades in terms of what can be accomplished using implants following mastectomy. This is here the difference that exists between the first publication of implant-based reconstruction in '71 and what we can reliably accomplish in 2020. And the same advance we've noticed in microsurgical reconstruction, where following mastectomy using autologous tissue, aesthetically pleasing reconstructions are the norm today, and that certainly cannot be said for years ago. One big change that we've noticed in autologous reconstruction is a shift away from muscle-based approaches to perforator-based approaches. And the goal for that was predominantly to reduce donor site morbidity. So the goal is to accomplish the same or more with less morbidity to the patient. And this principle can also be seen in the developments that we've noticed in implant-based reconstruction, where we have seen in recent years a transition away from muscle-based approaches to prepectoral implant-based breast reconstruction. When you look at the transition of the implant-based techniques, however, over the years, you cannot fail but notice that prepectoral reconstruction is essentially subcutaneous device insertion. And we know from the 70s that that was fraught with complications. And so I think two questions in this realm are justified. Number one, why the transition back? And number two, what has changed that allows us to offer prepectoral reconstruction with good or excellent outcomes reliably? So let's tackle the first question first. Why the transition back? And I think the reason for that is because of challenges that have been noticed and experienced, and certainly I've experienced them with subpectoral breast reconstruction, whether that being pain during the expansion process, animation deformity, and the like. And you can eliminate all of that by taking muscle out of the equation in your reconstruction so that you don't have a problem such as this one. On still image, this patient who has had bilateral mastectomy with implant-based reconstruction has a fairly decent outcome. But on animation, you can see a substantial displacement and distortion of the reconstructed breast that is not only aesthetically displeasing, but for the patient is actually functionally compromising, that prompted her to ask and inquire about prepectoral conversion, which was then subsequently performed. The important issue in surgery or in plastic surgery is obviously to minimize patient morbidity. And if you think about that conceptually, prepectoral reconstruction really is the equivalent to an SIEA flap in autologous reconstruction. If you think about the fact that an SIEA flap harvest, you really are not at all making any incisions in the anterior rectus sheath. That is truly the least invasive of the autologous options using abdominal tissue. And in implant-based reconstruction, prepectoral device insertion truly is the least invasive approach to it, as there is no additional morbidity beyond what the breast surgery team has done by virtue of performing the mastectomy. And so that allows us to confidently conclude that pre-pectoral reconstruction truly is the minimally invasive approach to implant-based breast reconstruction. The second question that we had raised earlier was what allows us to now offer pre-pectoral reconstruction safely versus in the 70s. So what has changed? And I think a variety of different things have changed. Surgical technique has changed in terms of ablative treatment. Mastectomies performed today are substantially different than they were in the 60s and 70s. We now have skin-sparing techniques, we have nipple-sparing techniques. With that comes, however, a potentially greater risk of ischemic complications, but there we now have imaging technology that allows us to really look at the perfusion and assess the quality of the perfusion of the skin flaps left behind. In addition to that, we have mesh products, be it ADM, be it absorbable meshes that allow us to not only support the soft tissue, but also control the device pocket. And then we also have superior devices today versus in the past. We have innovations in the tissue expander realm. We have innovations in gel technology that allow us to achieve superior clinical outcomes more reliably. Challenges remain, however, despite advances in surgical technique as well as technology. And these challenges can be grouped broadly into three different cohorts, if you will. Number one is seroma. Number two is infection. Number three is implant breakage. So let's talk about those. The risk of seroma has been reported to be anywhere between 2 to 12%. And one of the main problems with that, obviously, is in the realm of pre-pectoral reconstruction, that it does not allow incorporation of the ADM. But not only that, seromas actually have been demonstrated to be a risk factor for the development of an infection. And that is ultimately the Achilles heel of any implant-based reconstruction, because that puts the entire reconstruction at risk. And here we do have an opportunity with innovations in device development and technology to treat these seromas expeditiously at the point of contact. And we'll talk about this a little bit more. The impact of device innovation is very, very easily seen using this device, which is the AlloX2, which has a 2-port system. One port that goes into the conventional expander portion of the device, if you will, and the second port gives you access to a drain that comes to lie along the IMF, so the most dependent portion of the implant pocket. And by virtue of this design, it allows the surgeon to access the periprosthetic space very easily without the use of image guidance and without the use of any technical finesse, if you will. You just locate the port, you insert the needle, and you have access to the periprosthetic space. And I am aware that the panelists have experience to not only using this port for aspiration of seromas, but also to aspirate fluid for cultures, as well as to use this port, if you will, as a bidirectional valve, which is an off-label use of the device, to actually irrigate and wash out the pocket at the bedside. And more to that in the ensuing discussion that I'm very much looking forward to. Here, we see what happens when the patients come to clinic for the air to saline exchange. So what I do is that I inflate the tissue expanders at the time of the reconstruction with air only, and then when they come back to clinic, I exchange the air for saline. And what I also do is that I access the drain port, and more often than not, I'm able to aspirate fluid that is not has not been drained via the drains that are in place. And so that shows you the true value of this device, because it very easily allows you to address any seromas, even subclinical seromas. And we all know that there is always some fluid in the pocket that is undrained by the drains that we place during surgery. So what happens if you run into an infection? The patient comes, has cellulitis, and if you look in our literature, shy of a minor infection where we would only offer antibiotics, surgery is always a component of the treatment algorithm in treating infections. In this pilot study, or in this small experience that we've had, we actually used the drain port of the AlloX2 device to irrigate the pocket. So this was a patient who presented with cellulitis. Upon aspiration, turbid fluid was aspirated, and we sent it for gram stain. It was gram-positive cocci. And ultimately, it showed quite negative staph. But what we did was, in addition to putting her on antibiotics, irrigating the pocket initially with dilute betadine and subsequently irrigating it with stearosaline until the aspirate was clear. Using this protocol, we were able to salvage 2 of 3 patients who presented with an infection successfully without the need to having to take them to the operating room. And while the numbers are not huge, the impact for the individual patient was quite substantial. And I think that's the take-home message here, that you don't plan on using this, but it is nice to have access to the periprosthetic space when you have to. Now, why did that one patient fail? Well, there was a variety of reasons for that. Number one, I would never claim that this works in every single case. Number two, we do know that patients who have atypical bacteria isolated, and in this patient it was Proteus, that the likelihood for implant salvage or device salvage is not promising. So if anything, aspiration of fluid and detection of atypical bacteria can serve as a decision aid, if you will, to not subject the patient to prolonged IV antibiotics, but rather take the patient to the operating room for device removal, exchange, or whatever needs to happen based on the intraoperative findings. And this is that same patient, preoperatively developed cellulitis, but we wash out, ultimately the infectious symptoms resolve. And this is her after completion of expansion. And notice that I always under-expand the tissue expander, and this is final implant placement. And you'll see always a delta between the final expander volume and the final implant volume. We followed up this study, including more patients, and ultimately performed a comparative analysis between conventional tissue expanders and the AlloX2. And what we found was a reduction in time to drain removal. And that has nothing to do that is magically related to the characteristics of the device. The device does not dry out the pocket more readily than a conventional tissue expander, but rather it allows you to be confident enough to remove the device, to remove the drains when it meets drain removal criteria, whatever those might be in your practice. And why do I say that? Well, leaders in the field, when pre-pectoral reconstruction was introduced, were pretty firm and almost dogmatic about the fact that drains should remain in place for at least 3 weeks. And so if you remove drain prematurely and you did not have any access to the pocket, you may have felt somewhat uneasy. Having a device in place that allows you to access the pocket at any given point in time allows you to implement your regular drain removal criteria, and knowing that you still have access to the pocket if the patient were to develop seroma. And so that, I think, is the explanation why we have seen a reduction in time to drain removal in our practice. And on the second slide, as it pertains to postoperative complications, we basically see corroboration of the previous pilot study in which a subset of patients who developed an infection were able to be salvaged without an additional procedure. The third area, or the third challenge, the third area that I had mentioned earlier is implant rippling. How do we address this problem? And I think that this problem can be addressed at 3 distinct time points. You can address it at the very first stage of device insertion, of expander insertion, by choosing a tissue expander that has a narrower base width than the final implant base width that you plan on inserting. So that is a decision that you make at the time of the immediate reconstruction. The second decision point is really your choice of implant type at the time of the implant exchange. And the third one is a secondary correction or secondary revision, and that's autologous fat grafting. At any of these stages, decisions can be made that can increase or decrease the likelihood for implant rippling to occur. So the one patient that really taught me that is here. This is a 42-year-old female patient who underwent bilateral nipple-sparing mastectomy with expander placement and final implant reconstruction. And this patient was found to have some degree of rippling medially and superiorly. And my practice at the time had been to perform fat grafting, secondary fat grafting, to camouflage the rippling, and then just have the patient get on with her life. The patient challenged me, however, on this and asked whether I could think of other ways to doing it. She also didn't have enough fat, so she felt she wasn't comfortable with the idea of liposuction. And so in this particular patient, I changed the implant itself for same size, same volume, same dimension implant using the HSC plus gel. And in this particular patient, the implant rippling was no longer noticeable. And so that sufficiently addressed the issue in this particular patient. Now, what that taught me is that in contrast to breast augmentation, for instance, where you have a thick soft tissue envelope covering your device, the quality of your reconstruction and prepectoral implant-based reconstruction is determined by a greater degree by the quality of the device itself. And so I think it is important for surgeons to think about judiciously what kind of implants they wish to place, taking into consideration patient factors, the quality of the soft tissue envelope, and the like. And so what I want to show is just a couple of cases of patients who underwent expander implant-based reconstruction using this HSC plus gel without any additional fat grafting. And so this is a 48-year-old female who underwent right areolar sparing and left nipple sparing mastectomy. This is after expansion, and this is after implant placement. No secondary fat grafting. And again, you will notice that there is a delta between the final expander volume as well as the implant volume, with the implant volume always being greater than the expander volume. This is a 51-year-old female patient, bilateral nipple sparing mastectomy at the expander stage and then final implant stage. Now, what you will notice here, and I don't want it to be misunderstood, I don't say that using the HSC plus gel eliminates rippling altogether, but it seems to minimize it, at least anecdotally and in my experience. So what about DTI? That is something, had you asked me 2-3 years ago, I would have said I don't do it. I just do expander implant reconstruction. But as experience is gained in prepectoral reconstruction and you become more familiar with the breast surgery team and you collaborate more closely, you overall just gain more experience. I think that one can explore this. And I think it is a very powerful operation in the sense that it's a one and done almost, if you will. But again, you have to be very judicious in your patient selection, particularly when you're starting out doing it. And so what are the criteria, in my opinion, and in my practice that I implement to offer patients direct implant-based reconstruction? I only offer it to patients that are small to moderate size breasts. The mastectomy skin flaps have to be absolutely pristine, and the patient should not really desire a substantial change in breast size. So if the patient comes and is an A-cup breast and wants to C, obviously that's not going to happen. And so those are pretty strict criteria that I implement. And I think that this patient is an ideal candidate for direct implant reconstruction. No ptosis, small-breasted, wants to have roughly the same breast size, undergoes mastectomy bilaterally with bilateral implant placement, and we almost have a match of post to pre-op. And the same goes for this 37-year-old female, no ptosis, small-breasted, had pristine mastectomy, skin flaps following nipple-sparing mastectomy, and thus I felt confident that I could proceed with direct-to-implant breast reconstruction and get close to where the patient was beforehand. So if you summarize what was said, and I'm again looking forward to the discussion of the panel, in the expander realm, we now have an expander available to us through innovations in device technology that comes essentially with an insurance policy. The drain port gives you access to the periprosthetic space, and while it doesn't prevent complications such as seroma, it allows expeditious treatment thereof by being able to aspirate the seroma at the point of contact without having to send a patient to radiology for image-guided drainage or aspiration, for instance. So in my opinion, it truly increases the safety margin of expander-based approaches. And on the implant side, we have seen innovations in gel technology that seem to translate into clinical improvements as it pertains, for instance, to reduction in the degree of implant rippling that is noticeable. And at least in my practice, it has changed the rate of secondary fat grafting that I perform, as in it has reduced it. And with that, I'm very much looking forward to the discussion.
Thank you very much, Dr. Momeni, for all your presentation. That is very important info to include in this discussion. So with that, we'll get to the panel.
In implant-based reconstruction, we've seen a trend, and now we have essentially two different groups or cohorts of surgeons, those who exclusively almost offer prepectoral reconstruction and those who offer subpec, and some who offer both. And I think for the discussion today, it would be interesting to highlight, when do we prefer one over the other? Is there a role for both? Which patients would benefit from them? And how can we leverage existing devices and technology to increase the reliability of outcomes when patients present for reconstruction? And so with that, I would like to kick off the panel by just asking the panelists, what is the reconstructive modality and implant-based reconstruction that they prefer and why? So why don't we start with Peter, in terms of when a patient presents to you, what is your thought process, how you decide whether you go with one as in subpec versus prepec, and in terms of your device selection there?
Well, I would say about 90% of the time I'm doing a two-stage reconstruction, whether it's a delayed immediate approach with eventual flap or if it's a two-stage implant reconstruction. So I'm usually talking about tissue expanders in that first surgery for a variety of reasons, most of which is I work with about 6 different breast surgeons, and it really gives me the opportunity to gain control over the implant space and the shape of the breast, the footprint of the breast, and take, really, I don't want to say surgical ability of the breast surgeon, but just the dissection pattern away from the breast surgeon, and really allow me to start the breast reconstruction where I want it. We'll get into the discussion on prepectoral reconstruction or not, but like I'm usually talking about, it's going to be a 2-step process, tissue expander. My preference is to use the dual port expander for a variety of reasons I think we're going to get into today. But we generally are having that discussion with tissue expander as a first step, and then a discussion about prepectoral as my reconstructive preference in the right setting, which for me is knowing that the mastectomy flap is well perfused, number one, and number two, that there's no pectoral fascia involved with the tumor or muscle involvement of the tumor. Otherwise, it's a prepectoral reconstruction for me if those aren't existent. And then if the conditions are good, we're doing prepectoral, and if not, we're doing a dual plane technique. I think it's important for me, I always talk to the patient, even if I'm doing a single stage, a prepectoral reconstruction, I'm always going to convert them to a prepectoral reconstruction in the second stage. So I caution them about why one's better than the other potentially long term, but tell them we'll work towards getting there, and maybe some fat grafting and other techniques are involved in getting a good result, and it's a stage process. But we have the discussion about the pluses and minuses about each technique.
Great, thank you, Dr. Koltz. And Dr. Kanchwala, what are your feelings on the same topic?
Well, I think that fundamentally, breast reconstruction, really, whether it's autologous or implant-based reconstruction, really, in order to get our best results, we need to bring all the tools to the table. So what I've noticed in my autologous reconstructions is that quite often adding a small implant adds some structure and projection and enhances the result sometimes of autologous reconstruction. And similarly, on my implant-based reconstructions, adding fat grafting and adding some additional soft tissue volume can really augment the result and enhance the result of implant-based reconstruction. So really, I think the best looking reconstructions, and if fundamentally that's what we're going after, really come from an approach that utilizes every tool that we have in our tool chest. Specifically when it comes to implant-based reconstruction, one of the other things that's really important is to tailor your operation towards the needs of the patient. So for my practice, most of my reconstructions that are implant-based are 2-stage for a lot of the similar reasons that Peter mentioned. I mean, I want to minimize the variables to get the best result possible. And so for me, a direct implant reconstruction really misses the mark in my ability to sort of factor and really account for all the potential variables that can happen. So for me, it's a 2-stage reconstruction, typically a prepectoral reconstruction, but I still do some subpectoral reconstruction. As Arash alluded to, I'm not as dogmatic about it as much as it's a preference of mine to do prepectoral. I also want to make sure that I minimize complications. That's really, at the end of the day, patients don't necessarily, they certainly do care about the type of reconstruction I have, but they care even more fundamentally about avoidance of complications. That ruins an even phenomenal good result. And I've certainly had the experience of having an implant failure or an expander failure due to infection or other reasons, and eventually even being able to get that patient back to a good result, a very, very good result. But that experience was very traumatic. And so I wouldn't want to put a patient through that. So really avoidance of complications is central, but then using everything that we have at our disposal. And thankfully, we're at a time in breast reconstruction where we have a ton of tools in our toolkit to be able to really offer patients a very individualized approach to managing their reconstructive needs.
First, I guess I want to say, it sounds like I'm hearing from you guys that obviously for each patient, you have various techniques and technologies available. You're specifying each route that you take with each patient for their journey, specific to their needs. But overall, it seems like the three of you prefer pre-pec reconstruction in terms of the aesthetics, as well as the minimal morbidity to other structures like raising the pec. So as you morphed that, what kind of complications are you still worried about? What kind of technologies do you use to manage those? Let's start with you, Dr. Momeni.
I think that brings up a very important point, and I want to piggyback off of what Suhail just mentioned, which is minimizing complications. I think that we all experience our fair share of complications whenever we do surgery. The impact of certain complications, however, is different depending on the reconstructive modality you choose. If you compare, for instance, the impact of a seroma after free flap reconstruction versus pre-pectoral implant-based reconstruction, that impact is substantially different. While you probably are not even aware that the patient has a small seroma somewhere in a breast that has been reconstructed with a free abdominal flap. With a pre-pectoral reconstruction, that can then lead to non-integration of your ADM, or worse even, infection, and then ultimately reconstructive failure. And so you just need to be mindful when you embark on this journey of offering surgery to patients that complications will happen, you will encounter them. How can you facilitate your ability to treat them expeditiously? And so now if you think about in the realm of implant-based reconstruction, specifically my preference also as that of my friends here is pre-pectoral. Typically, there are some instances where subpectoral techniques certainly are still valuable, and we can talk about that some more. But in pre-pectoral reconstruction, if you now have a patient with, let's say, seroma, you typically don't want to wait for the radiologist to drain that under image guidance, or you don't want to put the needle over the port of the tissue expander and slowly pull it back until you're in the periprosthetic space, and then you aspirate only until the level of the fluid sinks below where the port is, but rather you want to be able to very elegantly aspirate the most dependent portion of the pocket. And so if you have, for instance, devices available that allow you to do that, well, that would make it advantageous. It doesn't prevent the occurrence of seroma, but it facilitates your ability to treat that. And so those are considerations that you have to make, I believe, when you offer surgery, that you choose your devices wisely.
Great. And how about Dr. Koltz? What kind of technologies have you used to manage complications, at least in your plan, in case they come up? Dr. Momeni was alluding obviously to the AlloX2 with the internal drain. Do you also utilize that? Do you use perfusion imaging? What's part of your plan?
Yeah, I think about the two biggest complications that I have, and Arash spoke about seroma formation. That's certainly something we have to consider all the time. You know, one of the things that operatively planning goes into that is certainly in my population in the Midwest, but you know, I remember from being in Philadelphia, similarly, larger breasted women who could benefit from any reduction in pocket space with a skin reductive technique and marking for your mastectomy surgeon. So operative planning going into it is really important. I would say at least half of my patients get some sort of wise pattern skin reductive technique in order to create an inferior sort of autoderm sling so that when you do have, you know, a larger potential space, you're closing that down as much as possible with a skin reductive technique in the prepectoral space. And that leads me to my second, you know, sort of issue I'm dealing with most commonly is wound healing complications. Big issue to deal with when you're talking about a prepectoral construct. You don't want to have incisional breakdown without some sort of autologous tissue beneath. And so that's not only possible with flaps with, perforator-based flaps, which I also do. But when you're talking about implant reconstruction, you can have obviously a dermal autograft that is perfused underneath your skin incision. So if you do have some wound breakdown, that you're not dead in the water, so to speak, and ultimately, losing a construct because of colonization or what have you. So I think those, I do use the two-port expander, the AlloX2, because also when you do have a larger breast, it is more difficult, as I'm sure my colleagues can attest to identify seromas. And you do get some cellulitis, and you don't know if that's dependent on or an association with a seroma or not. So I frequently, as soon as I get some cellulitis, I will access that second port and confirm that I don't have a seroma, or confirm that I do. And if I do, then I can culture it before I start antibiotics. So I'm more culture directed with my therapy, and start them on oral antibiotics after I get my culture. And then if it continues to resolve with oral antibiotic therapy, then we don't ever proceed any further, and then we get our culture results. I'm definitely with the AlloX2 getting my drains out sooner. I don't keep drains in any longer than 2 weeks anymore. It used to be a 3 or 4 week endeavor. But I think between those two things, reducing the skin envelope with pretty aggressive sort of wise pattern skin reductions, and keeping the lower pole of the breast, and sometimes getting complete coverage over the ADM construct with the implant. Even when I get some T-point breakdown, it doesn't bother me. And then we can treat that in any number of ways. But between those two things, the two-port expander and the skin reduction, I think it's treating both my cellulitis, seroma formations, and wound healing complications without too much stress.
Okay, great. So for you, planning to be able to really reduce that pocket, control that pocket around the construct, get good apposition, and then be able to manage fluid and test fluid it seems the most important to you.
Mm-hmm.
Great. And Dr. Kanchwala, similarly, what kind of technologies and planning are you using to think about these potential complications ahead of time and manage them proactively?
I think that, my thinking about complications have changed quite a bit over the last few years. And fundamentally, I used to think of a complication as something that was going to cause me to have to take a patient back to the OR or to do something, an event that causes a patient to come back to the office or back to the OR in an unplanned way. That was my definition of a complication. And that's why in the past, I used to always do subpectoral reconstruction, because when you do subpectoral reconstruction, you're protecting your expander. Your incidence of infection, seroma, these kinds of things is pretty low. Even if you have some wound breakdown, you've got muscle protecting your expander. Like you're well protected. The surgeon is very safe. The problem is if you look at pain, discomfort, animation deformity, the lack of an aesthetically pleasing lower pole of your breast as complications, and the overall patient experience. Every time they have an expansion, you need Valium, and patients are down for a day, and the chronic chest wall issues, not to mention the bathtub deformity. I mean, I could go on about the complications related to subpectoral reconstruction if you believe that those are complications. And so as I've changed my thinking to think about the patient experience as really being something that I want to be positive, largely positive, then the pain of animation and animation deformity and the pain of stretching out your pec, they're significant complications. And they're not just short term. For many patients, these can be a long-term chronic thing that they get used to, right? Those are the patients that win. They sort of just get used to it, like a hard contact lens. But then there are others that, for whom it's a debilitating operation. So as I think about reconstruction in general, it's not just subpec versus prepec. I want to do things that really minimize their complication, not just my complication, and increase their patient experience. So some things Peter just mentioned. Number one, the drains. I mean, if we were to poll our patients as to things that they care about the most, things that they hate most about their experience, it's drains. It's the top of the list of the things that they care about. Nobody wants a tube sticking out of them. It's a foreign thing. They're not used to it. It looks like blood to them of what's coming out. It's very uncomfortable. Even when you do prepectoral reconstruction, the patient's having no pain here. It's pain at the drain site. That's a critical issue. And so anything that we do that can minimize the need for, the number of, and the duration of drains, that's a huge win from the patient's perspective, right? Why do we leave drains in? We leave drains in because we don't want seromas that we have to deal with, right? We're worried about that issue. And that's an important issue because the consequence of a seroma is non-adherence of your ADM under best case scenario and potential infection and loss of the reconstruction under the worst case scenario. So it's an important thing to want to worry about. But the consequence of that is so significant. We leave our drains in for a long, long time. Before the AlloX2, I was routinely leaving my drains in 2 to 3 weeks, putting 2 drains in per side. I mean, that's, if you're talking about a positive patient experience, it's not exactly the most positive patient experience, number one. Number two, I think that there's a way about thinking about prepectoral reconstruction that's important. I think the analogy of a ADM use in prepectoral reconstruction as being a skin graft to the back of the mastectomy defect is a really useful analogy. Because when you do a skin graft, you bolster that skin graft, you make sure that there's no fluid and increased apposition between the skin graft and its wound bed. Well, we're trying to do the same thing with ADM in prepectoral reconstruction, right? When you get your drain out, if you have a 10 cc seroma, you're not going to be able to visualize a 10 cc seroma largely, right? But if you could drain that 10 cc seroma nonetheless, know that it was there, drain it, have that pocket be dry, I believe you're going to get an enhanced apposition of your ADM to your mastectomy skin flap. And that can only be positive for your overall reconstruction. So there's a whole host of things that about the AlloX2 that are useful in terms of the technology. It's a relatively simple thing, having access to that port, but it has wide-ranging implications.
Great, thank you, Dr. Kanchwala. Dr. Momeni, I will go back to you. You talked a lot about making sure and using technology and your techniques to really create a construct that you're minimizing complications. Obviously, I know you've published on the use of drains with the AlloX2, particularly in how you've used them not only to manage the early complications, but even to manage the more serious ones. You want to comment on some of your experience with patients?
Sure. So the main thing to take into consideration is that the AlloX2 does not prevent seromas from happening. I don't think that anybody on the panel is making that statement or claim. I think that we all have had for many years very clear guidelines as to when to remove existing drains. And that can be anywhere 20 cc's over 24 hours over 2 consecutive days, and any number of combinations of these duration and cc output. The reason why in prepectoral reconstruction we have been somewhat more resistant and at times using those existing guidelines has been because of our concerns related to, such as what Suhail and Peter already commented on, lack of integration of the ADM, infectious complications that happen. The downside of early removal of drains is too high as it pertains to the ultimate outcome for the patient. And as a result, the pioneers in prepectoral reconstruction typically have recommended at least 3 weeks of drain placement following prepectoral device insertion. And that has been the guideline that many surgeons have been following. What AlloX2 allows you to do is to go back to existing and time-honored criteria in your specific practice to allow you to pull the drain, knowing that you still have the ability to drain any existing fluid that accumulates within the pocket. So it is almost a safety belt. You don't plan on using it, but it's nice to have that insurance policy to access the pocket when such a complication then actually does occur. And it's just a matter of time that it will occur. If you have a high volume breast reconstructive practice, you will have a set percentage of seroma patients. And there is no denying that. So that's one. So it essentially built in a safety valve. The device itself doesn't reduce seroma incidence at all, I believe, but it helps management thereof, even after you've removed the drain. And that translates then into an earlier drain removal because you don't have this dogmatic, almost arbitrary 3-week cutoff. You can then take it out if the pocket is dry or if the pocket is seems to be dry by virtue of a low drain output. You just remove the drains. And when the patient comes back for the next spill, you can then easily access the drain port and aspirate. And if you get fluid out, that's great. That's the amount of fluid that otherwise would have remained in the pocket unbeknownst to you. So we talked about the seroma management and the greater ability of us to access the pocket and address any existing seroma, but more importantly, infections. And I think that we all have also dealt with infections in our practices. The problem if you don't have a window into what's happening in the periprosthetic space is that you're basically driving blind. The patient has breast erythema. You don't know, is it cellulitis because of an infection? You don't know, is it inflammatory? So you typically start the patient on antibiotics, either oral or you admit them to the hospital and you give them IV antibiotics. And let's say over the course of your antibiotic treatment, 24, 48 hours later, the redness has resolved. The treatment dilemma that you're facing now is, what do? You've given the patient IV antibiotics, the patient got better, you don't know if the patient had an infection or not, and even if it was an infection, what do you transition the patient to? So if you have access to the pocket and I believe Peter alluded to it earlier discussion, if you access the pocket and you get a fluid sample from the periprosthetic space, you can send that to the lab. So while you're treating the patient with broad spectrum antibiotics, you will get culture results back. So by the time the patient has recovered and has experienced resolution of the erythema, you typically have identified the bug and you have specificity. So you can then transition them to an oral regimen that is actually targeted. On the flip side, if you isolate atypical bacteria, gram-negative bacteria, you know, and there is literature to that effect, that any salvage attempt is probably futile. So you shorten the duration that you keep the patient in the hospital and on antibiotics, because we all know we want to give the patients the benefit of the doubt. We don't want to rush them back to the operating room unnecessarily. But if you find something such as, let's say, gram-negative bacteria in the periprosthetic fluid that you aspirate and the patient is symptomatically infected, well, at that point, you probably have to take the patient to the operating room sooner rather than later, as opposed to putting them on days upon days of antibiotic treatment while in-house. And those are the valuable tools that are given to you if you have a device that gives you a window into what's happening in the periprosthetic space.
I think the other important thing to think about, I know, and I second everything Arash was saying, is, you can also, it's a two-way port. So, and I'm probably maybe a little fringe, but you guys, the panel can discuss this, but I have on several occasions also injected fluid into the space almost as an irrigation, on a couple occasions with 1 gram of vancomycin, just in patients that I know I'm working towards a flap reconstruction and I'm just waiting for one thing or another to happen. And if there's a low-grade cellulitis or early infection that's asymptomatic and I'm not putting an implant in the second stage, I'm just staging them for autologous reconstruction. You can nurse them through a serial fluid collection, serial irrigations, avoid a trip back to the operating room and get them to a free flap reconstruction if that's where you're headed.
Well, one comment to that is I wouldn't even restrict it to just the free flap population, because if you think about it, if you have a patient who has an infection and you take the patient to the operating room and you don't see pus, but you wash the pocket out and then you place a new device in there, right? Mm-hmm. Now, if you are able to use that port to inject, and this is certainly off-label, if you then use that port to inject either antibiotic solution, or I typically use 1-to-1 betadine, then there are instances in which you can salvage that early infection all the way to the point of the exchange, at which point you will then take the patient to the operating room, take the old device out, wash anything that you would have done earlier, and then you can complete the reconstruction without having had to have the patient go through an additional operation. Does it always work? Of course not. Hopefully the number of patients that we have to treat in this manner is small, but for that small patient population, the impact is quite substantial. And I think without any cost to the surgeon, and certainly no cost to the patient, I think it is just a smart tool, a smart device that allows you to do these things without having to have the patient go to IR, drain placement, image-guided aspirations, and phone calls that need to be made, et cetera. So it just takes all those logistical challenges off the table because you have access at the point of contact.
Great, thank you. Suhail, yeah, let's go to you. I know you've had a lot of experience here.
Yes.
And I'll just mention, while it is an off-label use, to use it as a washout, and we need more data on it. I know you guys have anecdotal experience to share share with surgeons across the country. So that is the purpose of the forum. So please go ahead, share your experience.
Yeah, so I started to use an irrigation with betadine after I heard that Arash had a successful patient that he'd done that on. And so we talked about it. And so I've had 2 cases now, of the salvage. And I think, and to echo Arash's point, the salvage is really critical because for my 2 cases, the timing of the infection was at about 2.5 to 3 weeks. Now, if I take that patient back at 2.5 weeks or 3 weeks to remove that expander, it's not just the expander that's coming out. There's a high chance that that ADM is not incorporated to especially in the presence of any infection at all. And that means I'm taking out my ADM, I'm taking out my expander. Now, if I'm able to salvage it, if it's not frank pus, what am I going to put back in there? I'm probably going to put back a bare expander, or at that point go subpectoral. I mean, it radically changes the reconstructive algorithm. And in both of my cases, I was able to get the patient out to about 2 months and then do an implant exchange, and the ADM was incorporated. And so the critical thing is, it's not just that you're saving the expander, you're also saving that mode of reconstruction, because either you're going to do prepectoral without ADM, and some would argue that's okay. I have issues with that. Or you're going to do subpectoral, and it really dramatically has consequences beyond just a trip to the OR. So I think, again, hopefully it's a small subset of patients we use it for, but it's a really, it's a really cool way of getting more information. And it's rare that more information doesn't help you.
Sure. No, I think that's a great point. So thank you guys for talking so fully about your experience with technology, using it with your evolution of techniques. We've talked a lot about expanders. Let's talk a little bit about implants with and without a flap here. What is it you guys are looking for in a gel implant to be able to, you've gone this far with all the expansion process and creating that tissue construct. What are the characteristics of the implant that you think are important to support that? Let's go first to Peter.
Yeah, so anytime we're talking about prepectoral reconstruction, it's really important that in that first phase, we mentioned the incorporation of the ADM and trying to minimize dead space. The second part of that, when we do the implant exchange, we want to make sure, again, we're right underneath, hopefully well-incorporated ADM to thicken that flap. The other purpose of the ADM, I know everyone knows this, but just really worth mentioning, our goal is to create a space in prepectoral reconstruction to do fat grafting in. And if, like Suhail alluded to, some people would say you don't need ADM. I don't think that capsule over bare implant is a plane strong enough to support significant fat grafting. So I'm fat grafting all of my reconstructions to allow some space between my device that I'm eventually going to put in and the skin. But that does not replace the importance of having a device that's very form stable. So it's going to minimize rippling and is going to be as natural appearing and feeling as possible. So as cohesive of a gel as possible, but at the same time soft, which is the biggest difference when you're looking at the different cohesive gels. You want something that looks and feels natural. Feels is almost as important as looks, probably more. So in a lot of cases, minimizing rippling and feeling natural for patients. So when I talk in consultation with patients about the different devices that are available and why I choose to use the ones I do, I use majority of cases the 107s, the HSC Plus for the exchange, except in hospitals that I just don't have the option to use it, and I'm forced to use another device. And the reason really is just the cohesiveness that the shell-gel interaction, and we talk about rupture rates with implants. If there were to be, a shell that were to rupture, it's the highest shell-gel interaction is an important point for patients to understand, that they're not going to be having gel leak all over the place, aside from just the cohesivity of the gel. But it looks and feels natural, and really that shell gel interaction is really what the biggest touch points that I have discussions with my patients about.
I think just piggybacking off of what Peter just said is in prepectoral reconstruction, and I want to also reference a previous panel on breast augmentation that went into depth about implant technology and how that can be used in modern approaches to breast surgery, in that case, aesthetic breast surgery. In prepectoral reconstruction, more importantly, the true qualities of the device are unmasked, right? You don't have glandular tissue, and if you do dual plane augmentation, part of the pectoralis muscle concealing any underlying device. the reconstruction and implant-based reconstruction, the reconstruction is the device itself, plus some soft tissue coverage, be it ADM, and then the thickness of the mastectomy skin flap. And so your choice of that almost directly translates into the quality of the reconstruction you get. And naturally, you want to have all the points that Peter already mentioned, a soft, relatively naturally feeling reconstruction. Although we all have also, to play devil's advocate, we also have to be careful when we talk about feeling, because in contrast to the aesthetic population, the reconstructive population has loss of sensation following the mastectomy. So it always is, it has to be taken with a grain of salt when we talk about sensation in that concept. But I agree with Peter wholeheartedly that you would want to have a device that ideally has longevity in terms of, you know, low rupture rates. You want to have a device that is soft, but yet has internal structure and form stability. And I think all of those characteristics define or are the prerequisite for you to have reliable outcomes in a variety of different patients that present to your practice.
Great. Suhail, what has your experience been with different devices, cohesive devices to support reconstructive outcomes, and specifically with Sientra's HSC Plus?
Yeah, so I'm a relatively new user of the HSC Plus. I've only been using it for a little over a year now. And one of the things that I've had the experience of doing is actually going back and taking a patient who'd had another form stable implant from a different manufacturer and was going to treat that with fat grafting, but fundamentally, you know, thought that in addition to fat grafting, perhaps the issue was really the device itself. And so I've had a few patients now where I've taken and revised them and removed another cohesive gel implant and put in an HSC Plus. And I found that it's really dramatically helped with the rippling and prepectoral breast reconstruction. So now, you know, that's one of the reasons I switched over to using HSC Plus, is that I've seen the difference in an individual patient. But I think that it's useful beyond just prepectoral breast reconstruction. I've used it in my hybrid autologous reconstructions as well. And I like the implant because I think it provides, for all the reasons everyone's mentioned, it provides, you know, a cohesive implant without the sort of firmness that sometimes associates that level of cohesivity in other manufacturers.
Well, I think we've discussed a lot here, and you've given me great lessons and things to look forward to doing future episodes on. If you're watching this episode from home, please stay tuned. We'll be going into all these techniques and technologies a bit deeper, and I'm very excited that soon we'll be able to offer some really good surgical videos to go deeply into these techniques with these experts. So I hope you guys are excited about that. Once we get back to the OR, I know several of you are. But thank you so much for joining me. Any final thoughts in terms of just overall lessons for people trying to get great reconstructive outcomes? Let's go around the horn. Start with you, Arash.
Well, first of all, thank you for putting this all together. I think it is certainly a new world we live in. A lot of it is virtual, but I think I can speak for everyone on the panel that we're also excited to being able to go back to the operating room and actually do face-to-face work. I think that these panels and these events are hopefully perceived as very valuable, particularly for our residents and fellows as they go through, but also for surgeons that have already been in practice, because I can tell you that I certainly, even today, have learned quite a bit from Peter and Suhail. And I think there's just, there are always things that we don't know or have not considered, and there's always some tidbit of a lesson that you can take out for your own practice.
Great. How about you, Peter?
Yeah, so just to piggyback on that, I think the majority of the stuff, and we get all the fundamentals in residency, and I think just being the most recent out of training on the panel here today, although none of the people here are necessarily senior, but it's important to not just adopt everything that you learn in residency and your training as gospel and never changing. A lot of the products that I use and techniques are things that have evolved out of the basis that I got out of in my training, and new devices exist that you maybe were not trained with. So this forum is really key, especially for residents and early graduates from their training, to take into account the early experiences that we have with maybe products that might be new to you, to just hear that other stuff is out there that you may want to consider if you haven't tried it or even heard of it. So it's really, this educational forum is really great.
Great, thank you. And final thoughts, Suhail.
Well, I would echo everything that both Arash and Peter mentioned, and just would end with saying that fundamentally, we get our best results when we use all the tools that are available to us. And so not only are we trying to get the best results, but we're also looking for what are the coolest tools to use, whether it's ICG imaging or the use of an AlloX2 expander or whatever it may be. The more that we have at our disposal, it lets us just offer that much better of a product to our patient.
Great, thank you guys. I agree with all your points. I mean, I think it's so valuable that I heard all three of you say, continue learning for all the surgeons out there. As an industry partner, we continue to learn too through partnership with you. So I thank you for utilizing our technologies where they can advance your outcomes, and in the same page we learn from you, and then we could advance those technologies to match. And that's really what true partnership is to match the education with the device development with this pursuit of better outcomes. So that's what this show is all about at Sientra TECHnews. So thank you guys so much for joining us, and we'll have you back in the future for the next episodes. Have a great day, guys.
Thank you so much.
Thank you.